we report a soft tissue sarcoma. At the first step, we are supposed to be familiar with the grading system of soft tissue sarcomas, and also we are supposed to be familiar with the staging system of American Joint Committee on Cancer and the reporting protocols for soft tissue sarcomas. You can see here, grade is currently best predictor of outcome, especially metastases for the majority of soft tissue sarcomas. And also distinction between low-grade and high-grade sarcomas may influence clinical decision-making, especially adjuvant chemoradiation therapy. A group of soft tissue sarcomas, mostly cases harbor translocations, exists limited with limited or no value of grading beyond histologic typing. In case of limited biopsy material, it is sometimes not possible to make a definite diagnosis. And also some pathologists suggesting Ki67 proliferation index instead of counting mitotic figures. We commonly use Ki67 to evaluate proliferation activity of the tumoral cells, but in some, I know in some labs, it is not common to use Ki67, and it is a matter of debate. It is reasonable to use radiologic imaging to estimate the extent of necrosis in small biopsies when surgeon or clinicians ask you to provide the grade of the tumor with a small incisional biopsy. You have to use a radiologic image to assess the necrosis of the lesion. Okay, the most common grading system is FNCLCC, which is based on 3 items: differentiation, mitotic activity, and necrosis. And each of these parameters receive a score: differentiation from 1 to 3, mitotic activity from 1 to 3, and necrosis from 0 to 2. Based on differentiation, tumor differentiation is scored as follows. When sarcomas closely resembling normal tissue, it has a score 1, and when sarcomas for which histologic typing is certain, but it is not similar to the original tissue, you can give the tumor score 2, and when you have embryonal sarcoma or undifferentiated sarcoma, you have a score 3. Considering mitotic counts, if you have more, you have mitosis in 10 high power fields from 0 to 9, it is a score 1, and when you have from 10 to 19 mitosis in 10 high power fields, you have a score 2. When you have more than 19 mitosis, you have a score 3. And considering necrosis, it is necessary to evaluate necrosis not only on gross examination, but also it should be validated with histologic sections. And when you have no tumor necrosis, it is a score 0. And when you have less than 50% of tumor necrosis, it is a score 1. And when you have more than 50% of tumor necrosis, you have a score 2. And as take-home message 3, a diagnosis should be made before mitotic rate is determined, because we have some lesions with high mitotic activity, but they are not a real sarcoma. For example, nodular fasciitis is a tricky lesion and with high mitotic activity, but it is a true reactive lesion. Mitotic count should be determined in 10 high power fields, and also you can use 10 contiguous 10 high power field to assess the mitotic activity of the lesion. And also tumor necrosis must be confirmed histologically, and gross examination is not enough to report necrosis of the tumor. And also hyalinization hemorrhage should be excluded